All right, our plan now is to open this up for committee questions and comments, and I want to make sure we use every minute we can for that purpose, so I'm not going to say a whole lot.
Hi, Bob, this is Tracy. Shauna is queued up for a question.
Hi there, can everybody see me now? I see myself. I wanted to say thank you so much to all of the presenters for these great presentations. They were extremely inspiring and as well really helpful in terms of thinking about our charge for implementation. And so my question is spurred by several of the presentations, but I think all of you can address it. So I'll open it up to the group. I think it was Alyssa who talked about the family navigator and the role for that in terms of implementation. And our charge here is to really think about how do we implement high quality primary care with bringing in the patient voice in the community. And so I'm wondering, just from the panel, if that is a particular sort of action step that you think is applicable across the different groups that you represent. And if so, talk a little bit about that. And if not, are there other things that you're thinking about that we should be thinking about in terms of our process? Thank you.
So
Go ahead.
So this is Elisa, and so I will start it off with just it's something that both from a personal standpoint and working with families, that having families connect with other families, right? It helps to build in my mind the 3 C's: competence, confidence, and connectedness. When families connect to other families, they feel like, number one, we're on equal footing. That trust then begins to be established. And it's someone that has walked through and understands both the successes and the challenges that can be presented, especially when we talk about children and youth with special health care needs. I think it is an actionable step. I think one of the pieces, and this is something we're working on in another project at Family Voices, is looking at the financial component to ensure that piece is able to be sustained. We've seen some grant-funded programs really pop up, but the sustainable funding across sector, being able to continue to do it has continued to be a challenge. So I think that if you're going to take that actionable step, it's really important to look at how do we then fund that and address the continued funding.
This is Barbara Leach, and I want to echo what you're saying about the role of a family navigator. And I think that it is a particularly key role in the primary care setting because if you're using a family navigator, someone with lived experience, there is that immediate connection that levels the playing field, so to speak, so you don't have that power differential that we were talking about earlier. So you have someone that the family can connect to, immediately begin to build trust with, and that can really help them begin to navigate what is really complicated waters for families. And at the core of whatever it is that we do with families, with individuals who are dealing with these situations, trust is the foundation. And that is going to give you the platform in which you're going to be able to work on what really matters. And it doesn't matter what you do if you're working on the wrong thing or if your plan isn't a plan that really matters. So.
If I may, I would like to add to the conversation about families and including families. And it also goes back, I loved Mark's recommendation to include a question, a process question. I'll start my video. So AARP, we place a very large focus on family caregivers, the need to include family caregivers in the provision of care. And in 2012, my colleague, Dr. Susan Reinhart, who is a nurse, she produced a report called Home Alone, and there was a follow-up report in 2018 or maybe last year, Home Alone 2. And in that report, in that research, she and her team found that a significant majority, more than 50% of family caregivers who are responsible for providing the bulk of care, hands-on care to their loved ones, were providing very important nursing or medical tasks without ever having been shown how to do that. And not surprisingly, the people who were receiving that care ended up being unnecessarily hospitalized. And so AARP developed a model state bill called the CARE Act. And since then, since 2015, it's been implemented in 43 states. And what it does is it basically does three things. Upon admittance to a clinical setting, such as a hospital, the patient is asked, who is most likely to take care of you when you go home, so that we could enter that person and their contact information into the record. The second part is to provide that the hospital or the healthcare provider needs to provide ample notice to the family member for when discharge will occur. And before discharge, the provider needs to show the family caregiver what it is they need to do to take care of the loved one. So New Jersey was the second state to implement it, and the Hospital Association, a few years later, held a press conference, and they noted the CARE Act being one of 4 factors that led to unnecessary hospitalization reduction. So it's an important model bill, and most states have passed it.
So the one thing I just wanted, I think there are 2 of us want to talk at once. Hi, it's Gwen Darian. The one thing I just want to add to this is that what's really critical for integration of family navigators is to recognize and value their contribution and expertise. And often when you bring in peer support, I've been doing this for a long time, that is not given the expertise and lived expertise, and is not given the same weight as other kinds of expertise. And I think that's really, really critical. I think the other thing that's really critical is that there's support for education and training the family navigators, and having the family navigators also serve as trainers for other navigators. And so you can really increase the impact of that. But I think first and foremost, there has to be respect and valuing of the expertise of the family as part of the team, not just as a kind of add-on.
It's Jennifer. Oh, I'm sorry, Barbara, is that you trying to get in?
It's Amy, and
Go ahead.
I just wanted to add on quickly in terms of some of the model that you're talking about, and that in migrant health, and has been applied in other types of health as well. But I just want to bring in the community health worker model as a really important piece of the clinical team. And the community health worker can be, sort of like some of what we're talking about in terms of the family navigator, can be a layperson that receives training about various aspects of healthcare or health and safety. And as far as migrant health is concerned, the community health worker becomes a really important player in all kinds of health-related education, but also can be the clinicians' eyes and ears on what's happening in the community. So we've had scenarios where we've had a cluster of birth defects, and it was the community health worker that brought that to the attention of the clinicians. And so for us, we actually include that community health worker in our definition of what is a clinician. Our clinician is anyone from the physician specialist to the community health worker. And then what we strive for is that we help health centers to really recognize, and I think that the VA touched on this, but we really want to make sure that that community health worker is not siloed and becomes a part of that clinical team. So the integration of whether it's the family navigator or the community health worker or outreach worker, social worker into sort of the clinical care that's provided is really, really, really important, and that they have some kind of way of helping the provider to be able to understand what's happening in the community and help the community member be able to access that care.
I wanted to add to that the family navigator role is an important role, and it needs to be one where there is compensation. It also needs to be one where training is provided and is ongoing, and those navigators need to be supported. I think there is a recognition that peer support is a key element. I do think that having a family navigator on board in a primary practice helps build that partnership with the practice and with the clinicians in that practice. The navigator role is one of family advocate and helps that family become or that patient become their own strong self-advocate, which is a role that is really key to healthcare. I firmly believe that there should be nothing about us without us, no matter what the situation is when it comes to our well-being. No one else should be making all the decisions about what is good for me. And my voice should be the strongest voice because it's my life. And I feel that way about individuals with who have disabilities. I feel that way about people who have medical conditions. And, you know, I've been at this work for 30 years, and both personally and professionally. When you talk to your mom or your aunt or a friend and you ask them about their medical appointment and the medications, and they can't tell you what they were treated for today and what the medication is that they received, or really explain to you why they're having a procedure, that speaks volumes about the lack of communication that is going on in primary care practices. And that should not be the case. I think it happens more often when you're talking about unserved and underserved, when you're talking about people of color. And I think that there's this rush to get the visit over because you've only got X number of minutes. That's a whole different subject. But I think it's really important that self-advocacy is promoted and supported in primary care.
I was hoping to jump in just for a second. I 27 years ago, I was a social worker in primary care at the VA, and this continues to be an issue of concern. At the VA, we have built a family and caregiver advisory committee. It's a federal advisory committee, so we can understand how to best meet and treat the patient where they're at, but also to include the family. And you know, some of the things we heard a lot were things like include me in the conversation. When you're about to have a treatment plan established for your patient, make sure that the family member is there. And the one thing I would like to offer here is really leveraging the use of telehealth and video technology to try to get, if a family can't get into the visit, having a way to connect that family member so that they understand what the next steps are in the care is going to help benefit the patient, compliance with the, you know, whatever the the goal is and to help set healthy, achievable health goals. So, you know, I would just like to put a plug in here, and I'll tell you from the VA's perspective, when we went and met with patients who were recently discharged from the hospital and their next step was to go back into primary care, they said to us, I wish you would call me and do a video conference so that you can see, did I put the pills in the right box? Did I change the bandage correctly? Because that helps prevent potentially the visit to the next, a repeat visit to primary care, and then perhaps even an admission. So talking with the family, but my urge would be for us to try to expand. It doesn't have to be a face-to-face conversation to get the family member or the caregiver really understanding what the care is, the best care is with the patient.
Hi, this is Tracy Lustig with the National Academies. I have a question from one of our committee members, Bob Wyant. Dr. Wyant asks if the panelists think of oral health care in the context of primary care and what concerns they have about dental care.
This is Amy from Migrant Clinicians Network, and thank you for bringing up that question. For our population, this is an enormous issue, and we see dental care as part of primary care. I'm not sure the rest of the world does, and somehow they seem to cut our heads off when it comes to healthcare. So mental health, eye care, and dental care seem to be separated from other care that you can get. But for our patient population, dental care is huge, and we definitely consider it to be part of primary care.
This is Elisa with Family Voices. And I echo what Amy just shared. You know, especially for children and youth with special health care needs, they tend to have higher, more challenges around oral health, and finding dentists that can provide their oral health needs can be really challenging. And it's something that, you know, absolutely needs to be addressed from a primary care standpoint, but oftentimes it's not, and it is siloed, just like mental health and just like vision and then, I mean, you get to the financial component of the financial burden that's often on families to be able to access oral health care, especially when there are a lot of challenges. So absolutely, oral care should be included as part of primary care.
Hi, this is Winifred with AARP. Thank you for that very important question. And AARP policy supports Medicare covering dental services, as well as encouraging state Medicaid offices to cover dental services. First of all, it's an issue of primary care. Second of all, oftentimes it's an issue of pain management. Third, it's also about mental well-being. Because oftentimes when older adults, I'll speak about older adults, when they are experiencing severe dental issues, they are less likely to engage in the public and socially at all, and therefore become more isolated. And more isolation actually significantly decreases a person's quality of life, as everybody on this call would know. And it also significantly adds to Medicare costs.
And this is Gwendarian. I'd just like to add on behalf of cancer survivors, this is a one of a common and not often spoken about late effects of cancer, depending on your treatment, is significant dental and oral health problems. And somebody mentioned insurance in there, and we all know, I mean, it is, dental work is underinsured, but it is part of overall health care, and it is also a late effect of some kinds of treatment.
Hi, this is Tracy again. From our committee, I know we only have about 10 minutes left. I have Rebecca Etz and then Bob Phillips and Molly Cook, if if I wasn't sure if you were asking questions or just making comments into our chat, but we can start with Rebecca.
Thanks, Tracy. I appreciate it. So my question is actually to everybody, which I know doesn't help with the 10 minutes. So I will try to make it as fast and confined as I can. I listened with great, I'm an anthropologist by training. I listened with great interest in everything that you talked about. And as I thought about it, it seemed like most of your comments revolved around, I wrote it down, so I'm just going to take a peek here, connection, relationship, trust, integration, and advocacy. I would say there was also some discussion of access, particularly conversations about loss of work and how that affects insurance, and accountability. What I heard you talking about in terms of accountability was that we, as primary care, would be there for you when and where and how you need us. I didn't hear you talking about what often occupies a lot of the academic literature and what often occupies a lot of conversations within primary care. Quality measures, competency of the doctor and how you might know that, and the role of payment, particularly for on your side. I imagine it would be about insurance and how insurance gets in the way, but payment has become a big issue because primary care is really under-resourced. And we have an aspiration, which is to meet that definition that you all pointed to and said, you're not cutting it. So I'd really love to hear from you about what opinions you have about quality and some accountability related to payment within the healthcare system, and what those things would actually mean to you, and competency, sorry, and what those things would mean to you. Thanks.
I'm happy to start it off. As Mark at the National Health Council, and I think those are a slew of excellent, really important questions. From my perspective, when you get to quality, we've been dancing around quality for a long time, but it's only recently that we have involved patients and family caregivers in the development of quality measures. And I think we've looked quite heavily in recent years at outcomes measures, which are interesting and important, but are the outcomes that we care about? When you look at measures that are being evaluated, are they getting at the issues that we care about? Are they getting at issues that our providers care about? Are they getting at issues that payers care about? I think we have some challenges there, and I think we need to really take a hard look at what are the outcomes that matter. And when I look at research and even drug and device development, they've moved a long ways towards starting with the outcomes that matter to the patients first, and then figuring out how you address them. When I suggested earlier the 2 process measures, I think those are important. You know, these outcome measures are things that we all care about, but the reality is process measures can change behaviors in fundamental ways. And to one of your other points I think was critically important, we follow the incentives, we follow the compensation, and the reality is we don't value primary care the way we need to in this country. And that's a critical oversight. We are not providing the level of compensation, we're not providing the money, we're not providing the incentive for the right amount of times. We're not providing the incentives for you to actually engage and understand what's important to us, which I think I heard from every speaker here today. We've got to rethink those incentives. When I look at what's happening now, it's really about providing or creating a cultural shift that brings us back to where we were when we had country docs 50, 60 years ago, when you knew everything about me and my family, and were able to have a conversation and really help me or my family get to where I need to get to. We don't value that anymore. And we've got to look at this definition, which is inspirational. I think it's impossible for a patient to understand, and I submitted that as a written comment. But it's aspirational. That's good. We need to put the process around this so that it can work. And that includes things like engagement, navigation, the right incentives, the ability to have the time, the right measures that get at the outcomes that are relevant to the end users, us and you. And then we have to have some level of accountability, and that includes that intimidating aspect that needs to be folded in, where people, including us, are held accountable for the care we receive based on these agreed upon goals that we want. We're not there yet, but I would encourage you as you look at this, look at all three elements: the inspiration, the information, the intimidation to make this work, and then think of the different systems. We're seeing an evolution in Medicare Advantage. We're seeing evolutions in some of the managed Medicaid programs. We're seeing an evolution in the VA. We're seeing an evolution in some of the employer-sponsored plans where they are engaging and realigning incentives differently. We've only begun to scratch the surface, and if I could see something I would love in this report would be, how do we create that framework for this to be adapted in multiple settings and really drive this care in a very different way?
So I appreciate those comments and just want to make a few others to piggyback on that. I think, you know, when you ask the question of outcomes, and outcomes are critical. I mean, that's why we're here, is to drive better outcomes. But you have to matrix that against the patient's right to self-determine, meaning the patient as the center and the chief decision maker and what goes on with their care has significant sway in what type of care and how aggressive that care is going to be to yield those outcomes. And so it's very important that we keep that in mind. Also, I heard, you know, outcomes within the context of the physician. I want to go back to the comment I made earlier. In my opinion, the most effective way to deliver care is through a comprehensive care team. And sometimes some of those responsibilities will fall on multiple members on that team. And it shouldn't just be measured against one individual. I think if you want to have excellent care, you're going to have the team be responsible for what's going on, and everyone should be contributing to healthy outcomes to the extent possible. And again, recognizing that the patients themselves and their families will have some sway in the decision making. So it is a complex question. It requires several levels of thought, and it is possible, but it's not just as simple as, you know, we either have the light switch on or off. There's several little divisions in there that we hit just based on patient and family preference.
And I just want to add two really brief things to the last two comments. First of all, whenever we're talking about quality, we have to ask quality according to whom and for what. And then when we talk about outcomes, we also have to talk about outcomes, desired outcomes, as defined by, as also defined by whom, and defined by which stakeholder. So just in terms of reinforcing the relationship aspect of the healthcare provider-patient relationship, when we asked our patients what was the most important outcome to them, or how they felt about the relationships with their healthcare provider, even if they didn't have the medical outcome that they would want, they felt better about the entire experience and all of their outcomes if they felt that they were seen and respected by their healthcare provider. And so I think that's a really important thing, and that was even more important than the health outcome to them. So I think those things are very, very important. And the other thing I just wanted to say is we talk a lot about accountability and adherence, and we have to look at accountability and adherence in a bidirectional way. And Mark mentioned it, and I mentioned it in the beginning of my comments. The plans need to be co-created, and both the healthcare provider and the patient is responsible for that accountability. So thank you.
I would say something, but we're at 1 minute left. I typed a little bit.
I captured it, Wynn.
Thanks, Bob.
Thank you.